And after, we ask them to do a physical action, deep inspiration. And while we are teaching them, we discover different attitude, apprehension. Some have difficulty to feel how to block the air because they have the mouth open. Some are a little stressed and they want to do that too quickly. So we are discussing with them to do that quietly, no stress. So it's a continuous discussion to adapt to each patient and to bring them to the same situation. It's to master completely the method. And at the end, what often happens is that the patient came with the idea they could not do that, and they discover that it's easy because they have the feedback. And they are very excited often to help themselves, because we give them a tool to help themselves, and so they participate more than we could expect. Some old patients have more difficulty, that's not the word, they are passive, more passive in that way, but technicians are here to help them to understand. What can happen also is that some patients have difficulty and we decide not to do. It represents in our experience less than 5% of the patient prescribed for breath hold, with whom we decide not to apply, and it's only for one reason. They are old persons and they have a problem of comprehension. They do it, they listen, they try to apply the method, they apply the method, they do the breath hold, and after they re-ask you the first question of the beginning of the teaching, and you understand that if you apply this method with this person, too old person, there is a limitation. After every day it will be complicated. So it's a small amount of person with whom we decide not to do it. We have to think that more than 95% of the patient prescribed are able to do it easily, even patients who have important breathing difficulties. Patients who have emphysema, you hear they are breathing, they are tired. Firstly, we thought that we could not apply the method with them, but we discovered that it's the same situation as a normal person, because we don't ask them to do an effort. We ask them just to stop breathing, and it's not complicated for them to do that. They are in a quiet position, in a no stress attitude, and so that was previously not the idea to reach this patient, but our experience shows that whatever the situation of a patient, if he or she has a good comprehension, there is no difficulty to apply the method. Yes, we firstly use free breathing synchronization device because it appeared and appear today or always a simple system which should be easier to be implemented. But in the same moment we were discussing on the benefit of inspiration. And so this external device was dedicated to free breathing synchronization, so without inspiration. And because we saw the important benefit of deep inspiration, in a second step, the idea was, can we do deep inspiration with an external device? And so we compared the two on the same patient. We asked them to do breath hold with a spirometer and look at external visualization of abdomen position. And what we discovered that it is not possible to use an external device to manage inspiration, because patients have the arms up, so all the thorax and abdomen are fixed, quite mechanically fixed, and the only movement are in the upper part of the abdomen. And when you ask a patient to do a deep inspiration, this movement, anterior posterior movement of the abdomen, is only around 1 to 2.5 centimeters. It's a small size of movement. And firstly, it's not a problem, but you should understand easily that every day or at every beam, at every inspiration, this small movement cannot be reproducible so precisely. So if the patient has an abdomen movement of 2 centimeters and the next time is 1.5, it's 25% of the size of movement. You cannot have a correlation between this small movement and internal insertion of air in the lung. So the problem comes from the precision we could obtain from this external measurement. So we decided to stop using external device. And we saw later on in meetings and paper the problem of non-synchronization between external visualization and internal position of internal marker. So we really understood that our first vision was exact. So we maintained fully the idea of using spirometry. And what we can say about that is that using spirometry, so when you guarantee that at each beam, each session, you have the same amount of air entering the lung, you help to guarantee that the dosimetry based on the CT done at the beginning is the same, because dosimetry is based on a calculation on lung tissue, tumor tissue, so density affected a lot the calculation. And so we need to guarantee that the internal condition, volume side to side are the same from the first CT to each session. So this highlights the need of a reproducible condition of breath hold. The first presentation of papers about the decreased density was presented as a problem, because every physicist and oncologist know that if we decrease the lung density, we increase the build-up part in the tumor. So it was presented as a problem because it potentially is a problem. What we discover is that if we use a moderate inspiration, not a deep forced inspiration. When you ask for a moderate deep inspiration, it means before the feeling of effort. It's more comfortable for the patient. It's sufficient for the effect. And the important measurement we did in Phantom with different lung densities shows that the current calculation models applied in TPS today are able to calculate correctly in such domain of density. And the problem of build-up is now limited by the use of low energy, X-ray energy. So many papers show that we have not to use in lung 18, 25 megavolt beams. We limit to 6, 8, 10 MV. The build-up, it's an effect that is in evolution, because many lung tumors are decreasing during the course of treatment. So the cells on the sides of the tumor are week after week not in the same part.
So Dr. Garcia would like to thank you very much for your very excellent presentation on the deep inspiration breath hold technique. Thank you.
Thank you.
You're welcome.